From the News Channel 5 Network, this is Morningline with Nick Beres.
Good morning, everyone. Thanks for joining us on Morningline on this Wednesday. Nick Beres here. Good show. I hope you'll join in the conversation. As always, we'll get the phone number up there in a moment, and you're welcome to share in what we're talking about. An important topic. This some disturbing numbers coming out, and obviously we all know about the opioid epidemic, the problem that's been associated with it for years now. But what we've seen just during the past year is unprecedented here in the state of Tennessee. Almost a 30% increase here and nationwide from one year to the other. But 2020. Some 3,000 deaths from opioid overdose, the deadliest year ever for the state. Nationwide, about 93,000 people died from opioid overdoses. Just a dramatic increase. And I think part of the reason, and we're going to talk about that with our guests, has to be associated, I would think, with the pandemic. But even as we hopefully are emerging from that, those numbers aren't coming down. So what's happening with all this, and what kind of help is out there available is what we'll talk about today. 737-7587. But we have two great guests in studio with us this morning. Dr. Kristopher Kast is with us from over at Vanderbilt. You are with the psychiatry clinic there?
That's right.
All right. Adult psychiatry specialist. Appreciate you coming on. And Brian Sullivan, also executive board member with Prevention Alliance Tennessee, who, among other things, will be able to talk about the help that is out there and what we're seeing. Let me ask you first, Dr. Kast. You're a doctor of psychiatry there.
Yeah. Mm-hmm.
So the psychiatry, as opposed to some other medical field, how does psychiatry tie in with the opioid epidemic?
Yeah, I think that's a great question. So you can become an addiction specialist because I'm an addiction psychiatrist.
Okay.
So within other fields of medicine, but psychiatry is particularly important because about half of patients who have any substance use disorder have a co-occurring mental illness. And so
they're self-medicating?
Well, there is a self-medicating hypothesis. We kind of are agnostic about whether or not that applies in all cases, but often if there are co-occurring disorders outside of just having, and I shouldn't say just, of having an opioid use disorder, if you also have co-occurring depression, anxiety, PTSD, other mental health problems, it makes it, you're more likely to have worse outcomes for your substance use disorder as well as for your mental illness. So
Makes sense.
They kind of pile on.
So they're linked, is what you're saying. All
exactly.
Right. Well, as I said at the intro, I mean, the numbers are disturbing from 2020, are they not? I mean, I guess Tennessee here, we're talking about, 3,000 fatal drug overdoses, Brian?
Well, when you combine the 93,000 overdoses nationwide with the 300, with the nearly 1 million COVID deaths, it's the deadliest year on record.
Yeah.
And we know that isolation, and Dr. Kast, please correct me if I'm wrong, but the isolation does fuel, the chances of turning to a substance to cope because you're disconnected and you're away from the people that you love the most.
Mm-hmm. And maybe not getting out and doing the treatment and see, that's what I want to get at here a bit, is that I think obviously there was an opioid epidemic before the pandemic hit, but people see these numbers and they say, well, yeah, that's awful. But you know what? It's the result of the pandemic. We're going to get out of it, and it's not really as bad as we think it is, even though it was really awful even beforehand. Is it fair to say that these spikes in numbers with the opioid overdoses are directly related to the pandemic? I mean, that to me, and I'm no expert, seems like common sense, like what he just said. You're not getting the treatment. Obviously you're under a lot of stress. You're at home, and maybe it's easy to turn toward the substance.
Yeah, I think that we definitely have to include it as a factor here. I think the additional pieces to it are the changes in the fentanyl supply kind of getting into what used to be traditional heroin and how that is affecting what people are exposed to. So when you combine all of the factors that you're talking about with increasing exposure to opioids, and then you throw in a much more potent opioid that's more likely to cause an overdose with an initial ingestion or as somebody is having a relapse event, that combination together is probably driving the numbers.
And again, yeah, we've seen this. Fentanyl, much more potent, right? And there could be individuals that were abusing opioids, something, a separate type. All of a sudden they get fentanyl, they take the same amount, and it's too much for them to handle.
Exactly.
I'm just curious, maybe this is a question more for law enforcement, but why is it? Is fentanyl, it's more powerful, but is it cheaper? And why are they throwing fentanyl in there? Why these drug dealers? And I know some of it comes from China and elsewhere. What's with fentanyl? Why is that more of a money-making thing? Because that's what it all comes down to, is money.
I mean, there are economic factors driving that, and that the amount of opioid effect you get out of the total size or grams of substance that you have is greater with fentanyl.
Well, you would think if fentanyl is more powerful, these dealers could then parse it down and give a lower amount that you wouldn't overdose on. It would be on tar, and you'd have more doses to sell illegally.
Right.
But it seems like they're giving out the same dose as, say, maybe an oxycodone or something, and someone thinks they're getting that, and they take fentanyl and they're dead.
Yep.
I talked to a law enforcement officer in Pennsylvania just a couple of years ago about fentanyl and the fentanyl crisis that they were having up there. And one of the ways it was explained to me, now I have no reason to believe that this may be occurring in Tennessee, but they said that they had an issue with, if you think of the drug cartels as a marketing firm, in that sometimes they would put that out to be more powerful and to be more potent, specifically in the community, to market for that area. In our mind, we think, oh, that's killing people, don't go there. But in the addicted mind, they may think that's where I'm going to get the high that I'm chasing.
Ah, okay. I figure there's some kind of explanation behind that. The other part of it, too, I don't know, is obviously you talk about cartels, but the pharmaceuticals. And we know there have been some very high-profile, multi-million-dollar settlements, and they're still working some of these out with these companies that had, I don't know, they were just churning out. Is that not brought any help? Have the pharmaceuticals not pulled back a bit on just supplying nonstop pills to some of these mills?
So it has really been more state-led efforts in order to begin to curb that, and that we've started to, states across the country have created databases where every doctor who's filling any prescription opioid has to go and check for that person. Are there other folks filling prescriptions for them?
I've seen that at some pharmacies here.
That has decreased. So we have, if you look at the CDC data, continually decreased how many prescriptions per population over time. But even with that decrease, we're not yet getting at what the core issue is here. So limiting supply through the physician is important. Probably there are people who were suffering under that old kind of prescribing practice and now are still struggling, and it's going to take some time to get them into treatment. But there are other avenues into the opioid epidemic as well.
Okay, and I know there are viewers of this very show that through a doctor and because of chronic pain depend on opioids, and there's nothing wrong with that. And I'm trying to get a sense from you as the doctor anyway. Many of them will probably admit to you that because they've been on it so long, but they manage it, they are addicted. Okay, but it's not to the point where it's dominating their lives. Like I was saying that I've had an opioid before when I had torn rib cartilage. They gave me some, and I took 1 or 2 tablets, but I was very, very wary of it. I just had this fear of it, 1 or 2. I didn't feel a darn thing, okay? Maybe I had a low dose, but then I stopped and then I disposed of the remaining pills. But what should people think about when it's legitimately prescribed? How cautious should you be with these pills?
Yeah, I think that you were pointing out a couple of things there. One, that there are kind of 2 different groups here. One is the person who is brand new to opioids, being prescribed for the first time because they have a painful problem.
That was me.
And then there's the folks who have, because of how we have managed chronic pain in this country for a long time, gotten onto opioids and are maintaining on their dose for a long period of time under supervision of a physician.
Right.
I think to address the first group, those who are just getting opioids because they have a painful problem now, they've never had them before, the most important piece is knowing that you can develop tolerance, meaning that you need more of a dose to have the same effect, and withdraw, meaning when you don't have the medication over a period of time, you start to have aversive effects, like feeling like you have the flu, starting to feel like you need to have the drug in order to not be in withdrawal very quickly.
I was going to ask you, how quickly? Like, for instance, the doctor probably prescribed me enough pills maybe for a 2-week period, and I was like, within 2 weeks, if I took that, could I develop some of what you just described? And if that's the case, what the heck is the doctor doing giving me that?
Yeah, so the amount of time, or the length of a prescription keeps decreasing as far as what we're recommending. At this point, we're really not trying to give more than 5 to 7 days of a supply, because we know that going beyond that, people can start to develop withdrawal symptoms as they're coming off. a well-meaning friend may say, hey, oh, I have some, I know that it looks like you're in pain, and then they start to use that's not from their doctor, and then somebody can get into trouble from there. Now, I do want to separate that from the folks who are taking a stable dose over a long time from a pain specialist who are under their supervision and doing well. That medication is allowing them to function. Those folks have suffered because of the changes in prescribing recommendations.
Right, it's hard on them. I feel sorry for those folks.
Yeah.
It makes it more difficult, and they've managed it, and maybe that's the only way to deal with their chronic. Chronic pain is very different than from what I was dealing with. To be quite honest with you, I know in society we want a pill, and no one wants to feel any pain. I sure as heck don't. But how about toughing it out for a few days when you have some rib cartilage, and I'm not taking more than 1 or 2 of those pills, and I'm going to deal with a little pain for a few days. You know what pain does? Makes you feel alive because you feel it. Not the chronic bad stuff, but I'm sorry, man. I'd rather deal with a little pain than risk taking 3 or 4 or 5 or 2 weeks of opioids. Sorry, I'm just going to do that. I'm going to tough it out.
Well, there's also the issue if you have an excess of opioids. One of the things that our organization does, we work with Count It, Lock It, Drop It. And that means count the pills that you have, lock them up, and dispose of them properly, because we know that 4 out of 5 people that we talk to who develop an opioid addiction, they obtained it from a friend or a relative. So we want to make sure that people know, lock your prescriptions up and keep them safe.
This is incredible. And you lock them up. It's nuts. As we go to the break, I have a relative who was on some of the managed care opioids, and he was having quite a bit of work done on his house. Lots of people coming through doing remodeling, a lot of people. And he went to his cabinet after a couple of weeks when they were done, and those pills were gone. I guarantee you, one of those workers knew and probably is used to this. They're working in houses. First thing they do is they go look in the medicine cabinet, and they're looking for anything that has an opioid, and they took it. There's no question in my mind. They never know who. There were dozens of people coming through working in his house. But that's the point. It was in his cabinet there, and he went back to get his pills, and he got a refill, of course, but they were gone. It happens all the time.
Well, it's a body-altering, chemical, and if you have a loaded gun in the house, you lock that up.
That's right.
So why are your pills just sitting on the nightstand?
Yeah, he was naive and didn't think about it. Of course, for a long time, it was just him and his wife, and so he didn't have to worry about it, but he didn't think. I'm having these work done, it just doesn't occur to you. And that they had to go into his cabinet, find it, take it. Anyway, we're going to take a break. When we come back, we're going to get to some phone calls that have come in, and we'll go into more detail just about these numbers we're seeing and what maybe can help it, and then also, of course, talking about the assistance that can be out there for folks, whether they want to seek it themselves or someone that has a problem and you can maybe reach out to try to get them some help. We'll take a break and be back with more. Call us if you'd like right after this.